much, Drew, for the introduction, and thank you very much for the invitation. I'm really excited to be here. There's a lot to talk about, so I'm going to go pretty quickly, but I just want to make sure also that we have time for questions, so please bear with me. Okay, so today we're going to talk about RSV prevention and treatment and really focus on the recent advances as well as some future directions and some of the work that we're doing in my lab. Here are my disclosures. The learning objectives for today are to describe the historical and current epidemiologic trends for RSV disease, summarize currently available prevention and treatment options, and then explain some limitations of current therapeutic strategies for RSV disease. For my outline, I'm going to start with talking about, again, the epidemiology and sort of how it's changed, especially in light of the COVID-19 pandemic. I will touch briefly on the clinical manifestation of RSV infection with a focus especially on the pediatric population. And then I want to give some background on sort of the development of the novel agents for prophylaxis and treatment and kind of how we got to where we are today in 2023. I'll then shift the focus to the immunocompromised population, which is my particular research interest, and talk about RSV specifically in that population, and then try to end with some thoughts on future directions. Okay, so what are the past and current trends of RSV epidemiology? So RSV is everywhere in the world. There's a global burden of disease, and it disproportionately affects young infants. This is a result of a meta-analysis taking data from really several hundred centers from across the world. And they estimated that the RSV is associated with about 20% of all acute lower respiratory tract infections and between 13 and 22% of all infant deaths associated with, again, lower tract infection. Importantly, most of the deaths associated with RSV are happening in resource-limited settings. And I'm going to come back to that, so I want you to keep that in mind. What about in the US? Luckily, we do have a way of tracking RSV in the United States via a surveillance network run through the CDC. It's called RSVNet. And if you're interested, it has an interactive dashboard that you can really play with to look at past and trends of RSV by season, by age, et cetera. So I just want to orient you a little bit to this graphic. So along the x-axis is a year, one season, basically, from going from October to August, and the different lines are the different years. So if you look at the red and purple lines, those are pre-pandemic years, which are kind of the typical pattern of RSV, where we start to see some increases in cases in this time period right now, October to November, and then kind of a peak in January, and then a long sort of tail end of positivity. These are hospitalizations that are represented here. If you start to look what happened during the pandemic, so I want you to look now at this dark solid line, and this would be, during the pandemic is actually starting in the blue boxed line at the bottom, and you can see there was really very little RSV throughout this whole period. Starting in 2021, 2022, we actually saw this kind of earlier RSV season than we'd ever seen in prior recent years, which was unusual. And then finally, in the last season, 2022-23, if you all can remember, last time this year, we had a huge peak in RSV across the whole country. And of course, we saw that here in Seattle as well. Right now, where we are is these two data points right here. So we're sort of lower than we were last year, but I think higher than a typical RSV season, I would say. I mentioned you can also visualize this data by age. So if we look here, this is from November 2022 to September 2023, so last respiratory virus season. And this huge peak is the 0 to 4-year-olds. So this is the population that's most associated with hospitalization due to RSV. The second peak, which is just kind of a peak, but it's something that everybody is very concerned about, is the older, greater than 65-year range. So really there's this bimodal distribution of individuals that are affected by RSV and the individuals that get sick enough to be hospitalized from RSV. Okay, so what's happening locally? So this is data from the Seattle flu study, where you can sort of see the typical patterns of different viruses kind of in the 2019-2020 period. And then, as we all know, after the start of the COVID pandemic and all of the stay-at-home orders in Washington state, we really saw a complete kind of reduction across the board for mostly all respiratory viruses, and certainly for RSV A and B. Sorry, just. So here's another way of looking at it. This is also, again, using the Seattle flu study data, and you can see by virus, really, this period, which is the grayed out area, is the initial stay-at-home orders, and you sort of see a long depression in the RSV circulation in the population. So one of the questions that many of us have been thinking about is, could that depression followed by the high incidence that we saw in subsequent seasons, could that be due to a potential immunity gap or immunity debt? These are the types of the words that people use to describe this. So we were interested in looking at that, and one possible way to do that is to look at do a cross-sectional study and do a serosurvey to look at what the population level immunity is over time. So what we did is we collected leftover samples from Seattle Children's Hospital in two age buckets, 0 to 4 and 5 to 9 years of age. We were able to get some reference strains, so this was prior to the 2021-2022 season, and then two subsequent time points in the interseason periods. Excuse me. We also did the same thing using leftover blood specimens from BloodWorks. In adults that were either 20 to 59 or 60 years of age or older. Excuse me. We used a multiplex platform called MSD to evaluate the sero status of these samples. The nice thing about this platform is that it's a multiplex platform, so you can have 10 different antigens per well. It requires very little sample volume, 25 microliters, so we can do it across samples, like, for example, from children's, where we oftentimes don't have large volumes of leftover specimens. You do get a quantitative result out of it, and it can be more sensitive than ELISA. For our study, we were interested in looking at influenza, RSV, the endemic coronaviruses, MERS, SARS-CoV-1, and then, of course, SARS-CoV-2. I just wanted to show you the baseline data from this study. So this was, again, from individuals seen at Seattle Children's Hospital for different reasons. And if you focus on the RSV panel in particular, you can sort of see this strong antibody gradient where the younger age groups, less than 1 and 1 to 2, have lower antibody titers than the older age group. There is also a noticeable slight drop in titers from the less than 1 to the 1 to 2 year age group, and we hypothesized that that might be due to maternal immunity that's been passed on to the youngest infants. So if we take that baseline data and then we compare it to what happens in subsequent seasons, we can look at the change in immunity over time. So here is a heat map where the orange colors represent a decrease in immunity versus the blue, which represents an increase. Compare again to that baseline year. And you can sort of see that the RSV, which is on the top of the graph here, across the board on all age groups, we see a decrease in immunity. We can see that also for the endemic coronaviruses as well as flu A, and really it's most pronounced in the less than 5 years. When you look at the subsequent years, so now we're talking about 2021, 2022, we sort of see this rebound in immunity. We don't see the same change and drop, except again for that less than 1 years of age group, which is expected because of their age. But across the board, we see large increases to SARS-CoV-2, again, as expected, as the pandemic continued to infect more individuals, including children. And really, this kind of the RSV result is also expected because of the increased incidence we saw in the prior season. So one other question that we had was, okay, that's kind of looking in a cross-sectional way. Can we look at individuals in particular? And there had been one hypothesis that perhaps even the act of getting SARS-CoV-2 infection itself, could that actually affect your overall antibody repertoire and maybe also be another reason why we were seeing sort of increased cases of RSV and influenza. So we sought to do this in a prospective longitudinal cohort. We had 200 individuals that we screened for the likelihood of having high exposure to SARS-CoV-2. We did blood draws at baseline and then at 3 months and 6 months of age, and then they were surveilled for symptoms over that whole 6-month period, and if they were positive for any symptoms, they were instructed to self-swab. So as expected, individuals that were infected with SARS-CoV-2 had a nice response in their MSD titers to all of our SARS-CoV-2 targets. So here this reference line is the time 0 of infection to SARS-CoV-2. And you can see sort of all of the titers increase to spike, RBD, and nucleic capsid as expected. We then looked at all of our other targets on the MSD assay, and you can see overall really none of the titers to any of the other viruses are changing over time. So there's really not a trend to suggest that antibody repertoire is lost because of SARS-CoV-2 infection in itself. Okay, I'm going to move on to the clinical manifestations of RSV infection. So I mentioned before the bimodal sort of distribution of severe disease. In infants, RSV is the leading cause of hospitalization in the U.S. for children under 1 year of age. And really, the majority of these infants are healthy. 80% of hospitalizations are in healthy babies. There are, of course, high-risk infants that have even higher rates of hospitalization and severe disease. These are often babies with prematurity or congenital lung or heart disease. They may be immunocompromised, and then there are several genetic syndromes that are associated with severe RSV disease, including trisomy 21. In adults, RSV disease can be similar to flu, especially in the greater than 60 years of age group, with rates sometimes very similar to flu. Of course, within the older population, there's also high-risk features, such as having, again, heart, lung a disease or being immunocompromised. So if we look at hospitalizations on the left graphic here, you can very clearly see these high rates in the less than 1 year population, and then as you see another peak kind of starting at greater than 65 years of age and then really greater than 85 years of age. Notably, there is a significant difference by household income level and the rates of hospitalization, with those babies coming from lower income families being more likely to be hospitalized. When you look at actual mortality due to RSV disease, we do see quite a bit of mortality in the less than 1 year of age, really it's the greater than 65 year group that's had the highest risk of mortality due to RSV infection. So I'm going to focus a little bit on kids again, just because I am a pediatrician. In infants, really the typical pattern that we see is symptoms that develop about 3 to 5 days after infection and lasting about 5 to 10 days. Mostly they're limited to upper respiratory tract disease, but RSV can travel to the lower respiratory tract, and that's where we start to see more of the severe complications. Upper respiratory symptoms can be kind of as expected: runny nose, congestion, otitis media, with lower respiratory symptoms being more like cough, wheezing, tachypnea, or fast breathing. Oftentimes, babies will also have kind of nonspecific general symptoms, so fever is often a part of it, as well as apnea, and then poor feeding, which is also a poor prognostic sign. When we think about why and what the pathophysiology of a severe RSV infection is in babies, we really think it's related to the significant inflammation that they experience in their respiratory tract. So they have increased inflammation with impaired cytolytic function. You have eosinophilic and neutrophilic alveolitis, and then the mucus production also causes airway hypersensitivity. And because infant airways are small, they can really be obstructed very easily with that mucus. All right, so I talked a little bit about mortality before and the high risk features of infants, but here are sort of some of the numbers. So certainly infants with congenital heart disease as well as chronic lung disease are at high risk. Any congenital airway anomalies as well. These are very high risk infants. Luckily, we have seen some trends compared to earlier decades with some improvements in mortality rates, likely to do mostly due to changes in supportive care practices. But still, we still sort of see big differences in this higher risk group compared to the low risk group infants. Okay, so I'm going to shift gears a little bit and talk about where we are with new agents, again, for prophylaxis and for treatment. So here was the current status up until 2023. We basically had one drug, ribavirin, which can be administered either orally or inhaled. It was really the only option available, and it has many limitations. The efficacy is not fantastic. There are a lot of challenges to administering, especially the inhaled formulation, a very high cost for administrating, and really the big one also is really knowing when the timing of administration is and understanding if oftentimes it was given when it's sort of too late. The other available agent was palivizumab, which is an antibody and has been recommended for high-risk infants down to age 24 months of age for a long time now. So the challenge, though, with palivizumab is that it has to be given monthly. So it's an IM injection given monthly over the whole RSV season. So you can imagine what the challenges are with that. And then, again, also very costly. There have been several agents, antiviral agents, that had demonstrated virologic efficacy in challenge models, but really they have failed, unfortunately, to really achieve their clinical endpoints. And I'm going to share a little bit more information on that. So basically, we're at a state where novel strategies were desperately needed, and especially for immunocompromised hosts. And again, I'm going to circle back to that later. Okay, so what has been the issue that's made RSV vaccine development such a challenge for so long? So we have known about RSV and understood a lot about its, again, pathophysiology, for decades, but we have not been able to make advances on RSV vaccine. So part of the reason is that actually there was development of an RSV vaccine in the 1960s, which was a formalin inactivated RSV vaccine. Unfortunately, when those babies got actually infected with RSV, we saw that there was enhanced pulmonary disease in the vaccinated babies. And really, this kind of just led to a halt on the whole vaccine development program for literally decades. There are several kind of logistical challenges. There's not really a great animal model. There's problems with incomplete immunity to natural RSV infection in humans and how that might translate into a vaccine. And then very importantly, the primary target populations that we're talking about, young infants, are difficult to do clinical trials in. So the young infants themselves for vaccines might not have adequate immune responses. One strategy might be to vaccinate the pregnant person, but it's also a difficult population to study. And then in older adults, there has been concerns about immune senescence and what that would mean for vaccine efficacy. So in order to talk a little bit more about details of our the vaccine and how the vaccines were developed, to just tell you a little bit more about the structure of RSV. So there are several surface proteins, but the ones that have been important for focus because of their antigenic properties are really the G protein and the F protein, which is the fusion glycoprotein. So one huge development in the RSV world was really understanding the conformational changes that the F protein goes through when it binds to the host cell. So on the left panel, you can see these two conformations of the F protein. Here is the pre-fusion version, and then you can see the significant change it goes through post-fusion. And importantly, the transformation from pre to post results in several of the highly antigenic epitopes being hidden, basically. So understanding this structure of the pre-fusion RSV F protein was really critical to understand really what is going to be a good target for its antigenic properties. So this is an overview. I'm not going to go through all of this, but this is just an overview of kind of all the different approaches that are that are being investigated for RSV vaccines, as well as strategies for passive immunization. And I'm going to focus on just a few of these because of the where they are sort of in the pipeline. One other way to look at this is a nice graphic that's put out by PATH, which is here in Seattle, where they are constantly updating the pipeline for RSV vaccines and therapeutics. And luckily, we now have several agents that are in the market approved category here after really not having anything for a long time. So these are the ones that I'm going to focus on. So the two protein subunit vaccines are, one is the RSV pre-F protein vaccine, which was developed by, or is now being put forward by Pfizer, and then an RSV pre-F3, which is the GSK vaccine. Again, they're both protein subunit vaccines. They have different properties in terms of their adjuvant. I won't get into all of those things, but they're both protein subunit. The third, which is not yet approved or is not approved, but is being kind of is pretty far along in the pipeline, is an mRNA vaccine, again from Moderna. There are other vaccines that have used adenovirus vectors, but those are actually no longer in development, so we're not going to talk about those. Okay, so let's talk about the RSV pre-F protein subunit vaccine. This is the Pfizer vaccine. This was the phase 3 clinical trial that was done in individuals greater than 60 years of age with over almost 35,000 participants. And you can see the vaccine efficacy for a lower respiratory tract infection was between 66%, depending on whether or not you counted 2 symptoms versus 3 symptoms, in which case the efficacy was calculated at 85%. Really good safety profile. The second protein subunit vaccine is the GSK vaccine. And here, again, 25,000 individuals, again, greater than 60 years of age. And here the vaccine efficacy was calculated at 83%. Also, again, very good side effect profile. And finally, the mRNA vaccine, this data is not yet available, but was presented at a recent conference. 35,000 individuals, also again, greater than 60 years of age, and they have a vaccine efficacy around a little over 80%. So really great results in terms of vaccine efficacy. So very exciting to sort of see several candidates move through the pipeline. Here are the current ACIP recommendations as of this year. So any adult greater than 60 years of age may receive a single dose of RSV vaccine, but they do encourage shared clinical decision making. The decision making that they suggest is really thinking about who is the most likely to benefit. So probably individuals that are even older than 60 years of age are the more likely individuals to benefit. Obviously thinking about the patient's preferences and some characteristics of the different vaccines, but I won't get into that, but they've encouraged a shared decision-making model. Importantly, I mentioned age as being one of the high-risk categories, but there are several other high-risk groups that should be considered, and I just wanted to provide some of the data that's available from, again, these large clinical trials. I won't go through all of these different factors, but the important thing to note is that the ACIP, when they were evaluating these vaccines and making their recommendations, they felt that there was not enough statistical evidence to support even like a stronger recommendation in some of these higher risk groups. So just a note that the high risk groups are not really well characterized currently. And then importantly, there's really not any data on immunocompromised individuals because they were excluded from the clinical trials. Okay, and then one common question that comes up is really what should be the cadence of the RSV vaccine for individuals that do get it. So a little bit of this is to TBD. Obviously, we're just in the midst of a rollout right now, but for the data from the clinical trials suggests that at least through the 2 RSV seasons that were studied in the trials, they have durable vaccine efficacy. So we think at least for 2 RSV seasons we're good, but again, we're going to be getting more data about that going forward. Okay, I'm going to move on to maternal immunization. So I'm, again, harping this point about the youngest infants being the most effective. So this is the RSVNet graphic that I showed you before, where I've just added the youngest infants, so 0 to 6 months of age. And you can see that when you look at the hospitalization rate there, they are super high. So even compared to our overall 0 to 4 age group. So these are the high-risk infants. And so the challenge with this group is, of course, how to vaccinate them, because we know that young infants don't produce good immune responses to vaccines. Maternal immunization is an alternate strategy, and some recent advances in understanding the transfer of maternal to infant antibodies, specifically RSV-specific antibodies, has really helped us be more confident in this strategy for protecting the youngest infants. So this is the data from the pre-F vaccine. So again, the Pfizer vaccine, protein subunit vaccine, evaluated in pregnant people. And the outcome here, again, the primary outcome is an outcome in the infant, not for the mom themselves. Okay, so here are the curves, the vaccine efficacy for severe LRTI and for maternal vaccine was 70%. And then for medically attended RSV LRTI, which is kind of a step down, it's about 50%. So ACIP has also very recently made a recommendation for maternal RSV vaccination and have recommended a single dose of Pfizer's bivalent RSV pre-F vaccine between weeks 32 and 36 of pregnancy, and also they've put some time limitations on that. I'm not going to talk about the details of the debate on deciding those criteria, but if you have questions about that, we can talk about it at the end. Okay, shifting gears to antibodies now. So I mentioned palivizumab as being the only monoclonal antibody that we had available for a long time. It is approved in the US as well as the EU in less than 2 years of age for at-risk babies as well as preterm babies. But there are new candidates, which is the exciting part. So nirsevimab is a new long-acting RSV monoclonal antibody. And there are two key features of how the antibody was designed that have really been game-changing in terms of its use for infants. So first of all, a change in the neutralizing, in the antigen binding site has allowed for a fourfold increase in the neutralizing antibody of nirsevimab. Additionally, they have made changes to the Fc region, which has increased the half-life about 3 to 4 times. And the graphic on the bottom left is just demonstrating the half-life across different doses, and you can see this is measured out to 1 year plus post administration, and you see really a nice, pretty steady level of antibody over time. So there have been several pivotal clinical trials now evaluating nirsevimab for the prevention of RSV. So the first trial was in preterm infants. This was first published in 2020 with about 1,500 babies that were preterm. There was a reduction in both medically attended RSV visits as well as hospitalization due to RSV at 70% and 78% respectively. The second trial was actually then moving on to not just preterm infants, but late preterm and even term infants. And again, a large clinical trial, 3,000 patients. And here is the endpoints, again, medically attended or hospitalized due to RSV. And you can see the efficacy is around between 75% and 80%. So really a fantastic result. And then finally, individual babies that were at high risk because of heart or lung disease were also evaluated. This was actually a trial that randomized against palivizumab, which they should have been eligible for anyways. And instead of actually evaluating for actual infections, they were able to extrapolate the pharmacokinetic data to be able to make a conclusion that nirsevimab was protective at these doses in these babies as well. So really, in sum, when we look at a pooled analysis, again, of preterm, late preterm, healthy infants, we see about 80% relative risk reduction for RSV LRTI. Importantly, I think my interest again is in immunocompromised hosts. Unfortunately, we don't have data yet in this population, but we're hoping that some studies are coming forward. There will be several important considerations, including dosing, especially if we were considering it for older children with RSV disease. Certainly, there's a theoretical risk of development of resistance, and then also thinking really about what the endpoints could be in such a trial is important. Okay, and then the last thing about nirsevimab is just thinking about the durability. So I mentioned that there was a change in the Fc region that allowed for prolonged half-life. And when this was evaluated in the clinical trials, you can see here the two blue lines are the groups that received nirsevimab, and really they maintain high levels up until day 361 post-administration. One other thing that I think is also important that was evaluated in trials is that there was also a potential concern that administration of nirsevimab might actually blunt a natural immune response to RSV in these babies. But when evaluated by looking at actually the post-fusion antibodies in these babies, we saw high levels still equivalent to natural infection in individuals that didn't get nirsevimab, for example. So the conclusion was that we think that nirsevimab actually still allows for an active immune response in babies that receive it and still get infected. Okay, so the recommendations currently for nirsevimab, all infants, so this is quite different than palivizumab, right? So all infants less than 8 months of age who are entering their first RSV season should be considered for nirsevimab. And then there's a Second recommendation about older infants who are at risk for severe disease and entering their second respiratory syncytial virus season. And this is the list of the high-risk babies that are called out. Okay, so now we have a monoclonal and we have a vaccine that we can give to pregnant people. What is the best approach, and how should a clinician think about this? So, I think that this is still a work in progress, I would say, but we have no reason right now to really expect that there would be an additive benefit to doing both of those things. And so for the current respiratory virus season, the CDC has come out with some guidance statements about when you might consider one versus the other based on preferences from the family, but also sort of potential benefit or potential for not mounting a good response. For example, if the mom has a reason to be immunocompromised and might not have a good vaccine response, for example. The overall guidance, though, is that if a maternal vaccine was given within less than 14 days before birth, then that baby should be also considered for nirsevimab. But if it's been more than 14 days, then the vaccine should be providing adequate coverage. So it's sort of a one or the other approach right now. But again, this is all very new. Okay, and then I want to just circle back about therapeutics because there have been some updates. I mentioned before that there have been several agents that have gone through challenge studies and have really shown great effectiveness in terms of their antiviral properties and the reduction of viral load, but also their a reduction in symptoms. Unfortunately, as these drugs have moved into different patient populations, they really haven't shown the same efficacy. So many agents have now been put on hold, which has been frustrating. There are two new agents, sisutenadavir and a compound called EDP-398, that have also recently undergone challenge studies and that showed pretty promising results and have moved into clinical trial, later stage clinical trials. And so we're waiting on the results of these studies, and I think there's enough differences between the approaches that they've taken that perhaps we'll see a positive result, but that's sort of up in the air right now. So stay tuned for other new antivirals for RSV right now. Okay, the last part of my talk I really want to shift into kind of some of our group's own work in RSV and really focusing on the immunocompromised population. Okay, so what is the experience of respiratory viruses in hematopoietic cell transplant recipients? This is data from a surveillance study that we did at the Fred Hutch, where allogeneic hematopoietic cell transplant recipients were enrolled and underwent weekly surveillance for the presence of respiratory viruses. And not surprisingly, we saw all sorts of respiratory viruses over this time period, but rhinovirus was certainly the most common, then followed by the seasonal coronaviruses. And if you look at the overall incidence, you kind of see RSV kind of in the middle of the pack. But we do definitely see quite a bit of it. So over a 1 year period, it has a 7% cumulative incidence rate in this population. So, but why do we worry about RSV in particular, or for that matter, for other respiratory viruses in this population? So I showed you that image before of the infant that progresses from upper to lower respiratory tract disease, and this is exactly what we see in our bone marrow transplant recipients as well. When we look at the viruses that are most likely to progress to lower tract disease, this was a recent study that we published in a cohort of about 2,500 HCT recipients at Fred Hutch, and you can see RSV along with MPV, metapneumovirus, which is a closely related virus. These are the two viruses that really have the highest rates of progression, about 30%. once you get lower tract disease, or once a transplant patient gets lower tract disease, really there are quite a few outcomes that are possible. Certainly some individuals will recover and do fine, but a fair amount will have problems with airway obstruction and things like bronchiolitis obliterans syndrome, which can cause significant morbidity. Certainly that risk for secondary infections, for bacterial or fungal infections, and unfortunately we do see quite a bit of mortality from lower tract infection from respiratory viruses. So when we look at mortality, here's a curve looking at actually rhinovirus, RSV, parainfluenza virus, and influenza. And really, most of these viruses have similar mortality rates once you have lower tract disease. So there's something common, basically, that's going on once you get lower respiratory tract disease that's causing these patients to die. That data is mostly in adults, so what's happening in the pediatric population? Recently, a multi-center observational cohort was evaluated, and again, really just focusing on the RSV here, there are over half of these individuals required respiratory support within 3 months of diagnosis, and then quite a number of them also had significant complications. So RSV is certainly a problem in the pediatric HCT population as well. When we look at kids that are hospitalized, not only hospitalized but in the ICU due to after their bone marrow transplant, you can see that the impact of RSV is really high. So here I've highlighted the mortality rate in again, pediatric bone marrow transplant patients that are in the ICU, and it's super high, 66%. So what are the risks for progression to lower tract disease? I sort of outlined why we think that's kind of a critical junction, because once the lower tract disease is developed, there's a really high risk of mortality. So our group has done several studies where we try to understand risk factors for progression, and because of the size of the cohorts, we'll really be able to do multivariable analysis. And one of the big things that we found consistently is that lymphopenia is a significant risk factor for progression to lower tract disease. Interestingly, your antibody response, and specifically your neutralizing antibodies response, doesn't seem to impact whether you progress from upper to lower tract disease. And then once you do have lower tract disease, again, we've been interested in understanding various risk factors that are associated with mortality. Certainly the cytopenias are significant, but as is steroid use. And then one thing that we've been interested in is really what the effect is of ribavirin, and we do see that there is some protective effect of using aerosolized ribavirin, but not really for oral ribavirin, which is now become the standard because of cost issues with the inhaled ribavirin. So that's kind of our group's experience. Since then, several groups have tried to establish clinical risk scores. This one is from the MD Anderson group, MD Anderson Cancer Center, and then this one is from a European group. And kind of, they're similar. Basically, they calculate risk factors and develop a weighted score. And really, they're pretty good at predicting both lower tract disease as well as mortality. So this has kind of now become the standard in the field. However, I would say that when we do use these risk factors, risk scores for calculating disease severity, we actually find that the majority of subjects that are even at high risk by these scores are actually not progressing. So it makes us think about, what else can we do to better predict, what can we do to develop better prediction tools? And I'm just showing you, this is across the board for different viruses. Here's RSV here, but it's true for the other respiratory viruses as well. So one thing that we've been thinking about a lot is about what are the other factors that are not captured in these clinical risk scores that are influencing disease severity? Are there things that are specific about the virus, things like viral load, viral genotype? Could there be other environmental factors? Certainly the microbiome is being studied in multiple different types of population, but now also in the HCT population as an immunomodulatory factor. And then there's also thinking more about the host and what is the host response that's driving disease severity. So I'm not going to talk about all of these things, but I did want to focus a little bit about on the host response and talk about our work that uses transcriptomics in particular as a potential tool to help risk prediction. So thinking about, again, our model of individuals that progress from upper to lower respiratory tract disease, we've implemented a clinical study where we follow individuals post-transplant, and once they get an upper respiratory tract disease, we collect blood. Here I've just shown the PAX gene tube because that's the sample of interest for this study, but we collect a whole panel of blood. And then we follow those individuals and collect blood while they're still positive and if they develop lower respiratory tract disease. So one thing that we found is that when we do that and then we evaluate the blood for using a bulk transcriptomics, we actually see that individuals that are limited to upper respiratory tract infection, which is this light blue group or cyan, cluster differently than those individuals that then progress to lower tract disease. And again, this is at the time of upper respiratory tract infection. So we're saying that there's something different about the time when they have upper respiratory tract infection that's either that's protecting individuals from going on to lower tract infection. I've also overlaid like a clinical risk score on top of that, and you can sort of see that the biomarker-based sort of prediction is much better than actually just a clinical score. So we think that this might be one pathway to further risk stratify individuals. Furthermore, of course, you can do additional pathway analysis, and I've just sort of shown the broad categories we did in this study, which was actually a cohort of individuals that are infected with rhinovirus. But individuals that are have limited upper respiratory tract disease tend to show more of a cellular-based and especially T-cell response compared to individuals that progress later. So this is interesting and certainly something that we're exploring further. But in the meantime, what we're really been thinking about is how close to this time point can we get to really have a robust tool that's an early marker of disease severity. So this study, for example, depends on us identifying a participant that has a respiratory infection, then being able to get them into the clinic, do a venipuncture, get their blood, etc. But what if we had an option that was easier and might be not requiring an individual to come to the clinic? So one thing that we've been focusing on our energies on recently is doing decentralized blood collection, and specifically for the purposes of doing host gene expression studies. So the idea is pretty simple. We have virtual enrollment. Study kits are mailed to the participant. The participant performs the blood collection at home, and then the samples are mailed back to the lab, and then we take it from there for processing and gene expression analysis. This work has been critical with two of my collaborators, actually in the University of Washington and the Department of Chemistry, who developed this, what we call home RNA system. So here's what it kind of looks like. We use a commercial blood collection device. It's called Tasso. The participant collects their blood and then connects with a stabilizer tube, which in this case has RNA later in it, and then they cap it and mail it back to the lab. And so for this study that I'm going to share the results with, we were interested in SARS-CoV-2, so we identified individuals that were positive for SARS-CoV-2 and tried to enroll them very quickly, and then collected nasal swabs daily as well as symptom survey, and then they collected their own blood every other day for 2 weeks. So I'm just going to give you a few highlights on the types of analysis that we can do. So here is time on the x-axis, and these are different transcriptional modules or sort of pathways that you can further probe. And even on this kind of high level, you can sort of see that over time there's changes in which pathways are kind of showing up in individuals over this really short time period. So, for example, we can look at cytotoxic lymphocytes, and you can see this early peak and then a decrease over time. Similarly, the interferon responses, especially in the unvaccinated individuals that we enrolled, they had a high peak at the beginning with then a leveling off. And then, again, different patterns for different interferons genes can be elucidated. So once you do that, you can actually look at the individual genes within the pathway as well. And just to orient you, this is days post-symptom onset, and all of these boxes on the x-axis, and the y-axis is the value of the gene expression. So if you just look at the top 8 panels, it doesn't. I just want to point out that it's really important. It was really important for us to show that these signatures, which are reference genes, do not change in individuals over time. So we feel like that's some evidence that this is really a robust way of evaluating gene expression over time. But then when you start to look at, for example, particular genes that we might think are interesting, we can see the trends that are for here in the orange in the individuals that are infected compared to the green, which is the healthy controls, which tend to be that are basically flat over the time course. So you can take that further, and again, like this is a particular gene called IFI27, which has been shown to be an early marker both in SARS-CoV-2 but also in influenza. It's an interferon alpha and gamma inducible gene. The actual exact function is not totally known, but it does seem to be a pretty good biomarker. And so when you look at that gene in healthy individuals, again, over time, flat. But then when you start to look at individual participants, this is the green line here, you can see how the expression level of IFI27 actually correlates really nicely with the viral load, which is shown in red. And actually, this figure unfortunately didn't get loaded correctly, but it also, if you look at the symptom severity over time, there's a nice correlation between the gene expression, viral load, and symptom severity. Okay, I just wanted to end by saying, we have a lot of ideas on using this decentralized blood collection to look at RSV infection, and both in healthy as well as immunocompromised individual. We have a lot of plans in the HCT population to look at vaccine responses, again, because most of those individuals were left out of the clinical trials. And then, of course, there's a lot of new exciting studies coming forward with antivirals, as well as virus-specific T cells for RSV. So with that, I will end and just want to mention my funding, and thank you to so many individuals that I work with at Seattle Children's, at Fred Hutch, at the University of Washington, and really a group effort. This was a cake that I made to celebrate the maternal RSV vaccine results that came out this year. So we had a little party for our group because it was important. And I'm happy to take questions. Yeah.
What a great talk. So great to hear all the updates this year. My question relates to antigenic variation, and specifically those 5 mutations in nirsevimab compared to pazilivimab. Are they was it to account for antigenic changes over time, and is there any thought that these antibodies and vaccines will need to be updated as RSV adapts?
Yeah, very good question. I think a bit of that is what we're going to be looking at, right? As we so that's why these surveillance networks are really important for tracking, any changes to RSV in particular. I think RSV in general, especially the fusion protein, is a lot more stable than compared to like SARS-CoV-2, for example, and the spike. So we're not expecting huge mutations. I will say though, for me in particular, I'm very interested in tracking this in immunocompromised individuals because we know that just like for the other respiratory viruses, they have prolonged periods of shedding and they have intra-host evolution in the setting of different levels of immune pressure. So that might be one interesting population to keep an eye on.
That was a great talk, thank you. Do you have any speculation as to why those agents performed well in challenge studies and then failed in clinical trials?
Yeah, I think timing, right? So obviously a challenge study is very controlled. We know exactly when the exposure was and when the therapy is going to start. In the real world, this is super challenging, and I think we've sort of seen that with COVID as well. Antivirals, broadly speaking, are going to work best the earlier you give them, and the better that we are at like driving down the viral load is really going to prevent that inflammatory response and sort of all the kind of disease severity associated with it. So I think that's the central issue in most of these trials. Yeah.
Is there clinical utility or efforts for over-the-counter tests for RSV using nasal swabs, or maybe they already exist? I'm not sure.
Yeah, they do. It hasn't really picked up in terms of like widespread use. I think the utility, this is a hard question, right? So we have it for COVID. How does it help us? So certainly for, I think for, what's the right word? I guess for containment, right? It helps because once you know, then hopefully people are quarantining and not being exposed. I think that's one definite potential use. I think more critically, if it could easily turn into an action for antiviral, that would be, I think the real benefit for an individual, kind of public health aside.
I comment because it's just interesting, after the pandemic, everyone is just so used to, if they have symptoms, you do a COVID test, but it's so limited, But I think also people sort of want to test for other things, and the balance of what is the clinical utility, because, right, you should just be isolating, masking, but yeah.
Right, yeah, I'm sure we all remember people that were like, show up to an event and be coughing and like, don't worry, it's not COVID. I'm like, but it's like, it's something else. Like, I don't want it. Yeah. Great.
So I have one. So in current state, I know that Synagis is highly controlled in the hospital environment. Who gets it? How much each hospital gets allocated? Do you anticipate that something similar will be happening with our new antibodies? And how do we think that would affect Synagis and their role for it in the future?
Yeah. Maybe I'll take the second one first. There certainly is definitely still a role for Synagis, especially in this first rollout year, right? So access and availability is still going to be, I think, a huge issue. The other kind of niche population that I think about is transplant patients, where we actually recommend up until 2 years of age, but if you notice, nirsevimab is only until 19 months of age. There's a little bit of a gap there, so there's a role, I think, still for palivizumab there. I've been trying to keep track of what's been happening with the distribution and access, and I to be honest, I'm not sure I'm the best person to answer. I do know that there are several challenges, and so I think it's like, I think the next few weeks are really going to be important for understanding if a particular eligible baby can get nirsevimab, or if we should just revert to palivizumab until, because we don't want them to be vulnerable while they're waiting to figure it out. Yeah. Thank you so much.